the next section, we're going to tackle a few things. SVT first, then some ventricular arrhythmias. Heart blocks, I know, is a common thing that people get stuck on, and we'll touch a little bit about myopericarditis stuff as well. So let's start with SVTs. And a very brief recap of the cardiac conduction system. So you will remember that there is a sinoatrial node, which is the key pacemaker of the heart. You'll get electrical depolarization starting from this region and then flowing through both atria through specialized conduction tissue. Then they coalesce down towards the AV node. And after passing through there, through bundle of His, and then down the bundled branches, so the right and the left bundle branches, they terminate in a very complex and extensive network of Purkinje fibers. So that all gives you that rapid ventricular depolarization and conduction. So that's the key pathway of electrical conduction in the heart. So SVT obviously is talking about supraventricular. So if I draw a line, supraventricular tachycardias, the stuff that's happening up here. And generally speaking, SVTs, although by the actual definition above the ventricle could include fibrillation and flutter, they are often talked about in a separate way because they are so important and so distinct that they are referred to in a separate manner often. So when you're talking about a SVT in the common sense, it is generally these three entities: AV node re-entry tachycardia, atrial tachycardia, or atrioventricular re-entry tachycardia. Okay? For the purposes of this, we're just going to talk about SVT in the broadest sense, encompassing these three entities. So, on that note, let's tackle our first ECG. And again, I want someone to talk me through the ECG, but this is an 83-year-old lady with symptoms of dysuria, frequency of urinary micturition, and a new onset of confusion. The patient has a urine analysis that is positive for nitrites and leukocytes. And on initial blood tests, the white cell is 18 and there is an elevated CRP. Can somebody talk me through the findings on this ECG using our stepwise method, please? Someone new again. Come on.
So I can attempt.
Yeah, what's your name?
I'm Obina.
Obina, go ahead. Please go ahead with this.
Okay, so for this patient, I can't identify the patient because it's not written here. Also, the paper speed isn't written, and the calibration isn't written as well. Yep. Then moving on to check, there's some possible left axis deviation to normal axis. Then I can't pick out a distinct P wave. The QRS seems to be narrow and normal, and also not regular. So if I'm to calculate the rate, I'll probably, using the V1 down there, I'll count the number of R's.
Yeah.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20. So 20 by 6 would give us 120, about 120 beats. So the heart rate is about 120 beats.
Yeah.
Now, there are some fibrillatory waves.
Okay.
So, like if we use the V1 down there, just down there, you can see that you can't make out any particular, P wave. Then just, I can't use the cursor, but yeah, there's some fibrillatory waves down there. So my diagnosis here would be um possible atrial fibrillation.
Okay. Just tell me a few more words extra beyond just atrial fibrillation.
Um,
You've told me the answer already.
so well, the
Well,
rates
what's
would I
relevant?
say the heart rate of fast
Correct.
AF.
Yes, and you know that actually you shouldn't say fast AF because atrial fibrillation is fast in the atrium, isn't it? It's very fast. It's
Yeah.
300, 400 beats per minute. What you should say, if you want to be accurate, is atrial fibrillation with a fast ventricular response. Yeah?
Okay.
And remember, it fits in, right? We've got a lady who is elderly, who's got urinary symptoms, inflammatory markers that are up. She's confused. So it's probably atrial fibrillation, fast ventricular response in the context of a urinary sepsis. Yeah, very, very common sort of clinical scenario. Very briefly, how would you treat?
So for this patient, well, first of all, treat the urinary symptoms, the possible urosepsis, urine cultures, blood cultures, IV fluids, if required,
Yeah,
oxygen and antibiotics. Then, given that her heart rate is fast, and then I don't know, well, depending on the duration, I might consider, or I would consider, and then considering other comorbidities as well, and other medications that she could possibly be on, I would consider a rate control, and for her, I would also possibly do a chart fast,
yeah,
and then
good.
evaluate if I should anticoagulate her or not.
Very good. So just a few extra points to add to that description. So absolutely right. Treat the underlying precipitant cause. So treat sepsis, antibiotics, fluids, etc., etc. Then I wouldn't use rate control straight away because the driver for this is the infection. So I would focus on treating aggressively the infection first. I would, as you say, look at the CHADS VAS score and see if this patient would be appropriate for antibiotics. And I can tell you, just because of her age and things, she's highly likely to fall into the bracket of needing anticoagulation. I wouldn't try and cardiovert her or anything like that. We don't know how long she's been in it. So what I would tend to do as she starts to improve from the infection, give her some rate control once the infection is getting better if needed, and then anticoagulate, yes, highly likely. And if still there after the treatment of infection has completed, I would probably arrange for her to see cardiology with a view to a cardioversion because we think the precipitant of the AF in this scenario is the infection. All right? Is that clear, everybody?
Can I just double check? If the infection clears up the AF with RVR, would you need that follow up, or would you just leave it?
Yeah, you probably would. So then, good question. So obviously in that scenario, you may have started anticoagulation, right? I would keep the anticoagulation on board. The reason is that this lady at her age is probably we don't know her full risk factor profile, but she's probably got a significant CHAS-VAS score. So you don't know upon discharge if she's going to go back into AF, right? So better to err on the side of caution, leave anticoagulation on board, but I would absolutely arrange for some follow-up with some Holter ECG monitoring to see, is the AF coming back or has it settled? Often it will settle with treating the precipitant, but a lot of people don't know what to do, and I err on the side of caution. So conversely, however, if this patient was, I don't know, 40 years age, then the CHAS-VAS would be low. If the AF resolves, I maybe would seek less aggressively if it's back, because it's unlikely to be much more of a problem at 40 than it is at 80. At 80, AF is very prevalent. Yeah. So that's the rationale behind your question. Does that make sense?
Yeah, thank you.
All right. Common scenarios. Let's go into another one. This is a 45-year-old gentleman with a 24-hour history of intermittent palpitations, and has a reduced exercise tolerance, and goes to see the GP. GP does an ECG and finds it's abnormal and refers to A&E. The patient is not complaining of any pain. There's no blood pressure issues. There's no signs of heart failure. Can someone new talk me through this ECG and next best steps, please?
I can give it a go.
Go for it.
Um,
Sorry, I didn't catch it.
it's Ben.
Ben, go for it.
So first, looking at the rate, it looks regular. Can't discern the P waves at the moment, but I'll just get the rate first. 1, 2, 3, 4, 6, 7. Says about 7 to 8 blocks between the R intervals. I can't do that quick maths, but I think that's less than.
Remember the easy way when you've got an irregular heart rhythm is to do
yeah.
what?
1, 2, 3, 4, 5, 6, 7, 8. So 8 times 6 is 54. Yeah. So that's slightly bradycardic. Then in terms of axis deviation, I think it looks normal.
Looks all right, yeah.
Yeah. And yeah, it's not a regular rhythm, as you said. The PR interval, I think, is just on the cusp of normal. And the QRS is narrow, no obvious ST changes. But I mean, I don't know at what point in the kind of systematic interpretation of an ECG this is, but it just looks like a sawtooth pattern.
Yeah.
On the rhythm strip, which would indicate atrial flutter.
Yeah, very good. So would you comment on the PR interval then?
Probably not, because you don't know where the P waves and the T waves are.
Correct.
Because they're too close together.
And also it's so irregular, right?
Yeah.
So tell me one more fact about this. You've got pretty much everything. I would question your 8 times timetables though. So it's about 48, isn't it? 6 times 8.
Yeah. Take your word for it.
No, don't take my word for it. Just look at it. But essentially it's bradycardic, isn't it? It looks slow. Yeah?
Yeah.
It looks slow. And I would say to you, if it's flutter, which you've said, what else can you say about it? You mentioned the word blocks before. What would you say about it? Looking at, let's say you just look at rhythm strip 2.
Yeah. Well, I think you would expect flutter the heart to be running fast, wouldn't you? So bradycardia would be an uncommon finding in that? Or you couldn't.
Well, it's more the question that you've got a very irregular number of flutter waves, sawtooth waves, as you said.
Mm-hmm.
For each RR interval, suggesting that there is a variable AV conduction block. Yeah.
Okay.
So so very briefly, what that means is in things like fibrillation and flutter, as you can see here, the atrial rate is you can define, right? Because there's a P wave every large square. Yeah.
Yeah.
So it's very fast. It's nearly 300, probably not quite, but nearly. So it's a super fast atrial rhythm, but the variable block means that the AV node, which as you know is a junction box between the top and bottom of the heart, is not that slick at conducting these very fast atrial depolarizations. So it's selectively letting through sometimes every fourth or fifth beat, sometimes more. It's variable. So, but you got the nuts and bolts of this. This is someone who's got atrial flutter, which is more on the slower side because of variable block. What are your treatment principles here? And I'll refer back to the story, 24-hour history of palpitations.
So if you're confident in that timing,
Yeah.
I think, I'm not certain, but I think you'd treat it in the same way as atrial fibrillation. So you could either go with rate control if you weren't confident that it was less than 48 hours within presentation, or you could go for rhythm control if you are confident of that timing. And I think you can choose between cardioversion chemically or electrically.
Yeah, we'll come to that, Ben. So you're right. Strictly speaking, and it's somewhat an arbitrary number, this 48-hour cutoff, yeah? If you are confident that it's less than 48-hour duration of history, then in essence, you could, and this is the common practice, give, for example, a shot of low molecular weight heparin, initiate them on a DOAC, and get them cardioverted. Now, you can try to do that chemically. Often the drug of choice is flecainide, or with a direct current electrical cardioversion. But for that, you need anesthetic support to sedate and make them asleep. So that is possible. If you're not sure of the time frame being 48 hours or less, then you should wait. And the 48-hour really means that have they been in the rhythm long enough for them to have clot formation within the atria, in particular the appendage? Because when your heart is going in fibrillation or flutter, it's not contracting properly, and therefore you get stasis within the upper chambers and an increased tendency for clot formation. So if it's been longer than 48 hours, then there's more chance of clot. If you then cardiovert them, then your heart, let's say there's a clot sitting inside, you cardiovert them, whether it's with drugs or cardioversion electrically, you then restore sinus rhythm. If you've got a clot sitting in the heart somewhere, let's say the left atrial appendage, which is the commonest site, and now you restore normal contraction, remember, it's in the left side of the heart, it could now embolize, be contracted out into the body, let's say into the head, and cause a stroke. Yeah? Because you've already got the clot formed. So that's the problem. So if you're not sure, you simply rate control them, anticoagulate them, and then you defer cardioversion for at least 3 to 4 weeks. Get them followed up by cardiology and do it that way. Does that make sense, everybody?
Yeah, thank you.
Good.
Sorry,
Well done.
So my question is, sorry, can I ask please? So if you're seeing this patient in a local GP practice, you wouldn't send this patient to the A&E?
Depends. It depends, right? Because if you saw this patient in GP land and they were very, very symptomatic with palpitations, yes, you probably would, because you probably as a GP cannot do all the management that is needed, right? Acutely and in the short to medium term, because this patient clearly needs medications, anticoagulation, and then probably some follow-up with potential cardioversion, which you can't sort out. Yeah. So I would, and if you admit them as a A&E doctor, you would observe them for at least 24 hours, do all the usual blood tests, see how they behave. Do they revert back to sinus? Do they go? So remember, some of these patients can go tachybrady, they can go fast, slow. There's so many things that can happen here. It's difficult for you to manage in an isolated primary care setting. So I would say yes, refer to hospital. Make sense?
Yeah, it does. Thank you.
I'm going to move on because we spent quite a lot of time on this one, but I think you've got the general principles there. Let's move on to this one. This is a 40-year-old man with palpitations and breathlessness, denies chest pain, blood pressure's okay, he's alert. You have a listen to the chest. There's some very, very faint palpitations, but nothing significant, no obvious sort of overt heart failure. You send some bloods off and you're doing, all the other bits and pieces. What does this ECG show and what you're going to do? Someone new, talk me through it, please.
So, myself.
Please go ahead.
Yeah. All right. So again, so this now the calibration for this. So this way we can see some P waves receiving the R waves, so that the sinusoid. Then
I can't hear you very well. Sorry.
Sorry. So can you hear me now?
I can. Just talk a little bit clearer if you can. There's a bit of background noise. Yeah.
Okay. So sorry. Yeah. So so it's sinusoid, and then say normal axis deviation. Then in terms of the weight,
Go on.
Weight of about just below 300, because it's just one big box in between. And so other things I can find. So I can find that the P wave, the PR interval is shortened. So it's just about 2 boxes to the PR interval, and it's meant to be about 3 to 5 boxes. So it's shortened. And I can also see some delta wave as well. I can see the delta wave, the upstroke of the delta wave. So likely this is SVT on the background of Wolff-Parkinson White syndrome.
Okay, so you think this is SVT with on the background of Wolff-Parkinson White. Okay.
Yeah.
Does anyone want to give any alternative description?
Can I comment on that, please?
Please do. Who is this?
My name is Lisa, and another option I would probably suggest is one-to-one undulation, flutter with conduction one-to-one as one of the options.
How can you tell that?
Well, it's just very regular and usual maximum, as far as I remember, flutter frequency would be 300, and we have 300 here as far as I see. So that's what would make me think about that probably.
Yeah, I mean, I think the problem here is that you can't really tell. Yeah. This is super fast. This is, if you, as the other gentleman said, this is just over 1 large square. So it's not 300, but it's pretty close. It's something like 260, 70 or something. The P waves, I'm not sure you can discern, because this might all be T wave stuff. The P's that you think are here might just be T wave stuff. It's hard to know. So all you can really say confidently is that there is a narrow complex tachycardia. Yeah. For those of you who are very keen-eyed, you can actually see that there is a incomplete right bundle branch block morphology, RSR, but that's of no real bearing. The key thing is that this is a super fast, narrow complex tachycardia. I don't think I can comment and say that there is a delta wave here. I don't really see a obvious slurred upstroke of that initial thing. So I'm not sure I would say that. I would just say narrow complex tachycardia rate 250 plus. How are you going to manage this patient, the original person that described this, please?
It's, we can do Valsalva maneuver.
Very good. Yeah. And if that didn't work?
Carotid massage.
Is that still done nowadays? Not really.
If the patient denied for hospital for further anything like
It's not really
actually
recommended nowadays, if I'm honest with you. So what else could you do apart from Valsalva? If Valsalva did not work, okay, that's fine. We're not sure.
Adenosine we can give IV.
Yes, correct. Adenosine.
With cardio monitor as well.
Yeah, absolutely. Cardiac monitor is critical if you give adenosine. All right. I'm going to briefly refer to this guideline of adult tachycardia from the Rhesus Council. It's quite simple in the sense of you look at that patient that you had with the ECG of 200 something and you go, are they unstable with life-threatening features? Meaning, are they in shock, hemodynamically compromised, low blood pressure? Have they had syncope? Have they got myocardial ischemia? Have they got over left ventricular failure? If they don't, then you've got some time. And then if you look at the QRS, so if you've got no life-threatening features, no. Is the QRS narrow? Yes. Then you do vagal maneuvers. If ineffective, adenosine. That's essentially your key steps. If it's irregular, then it's probably atrial fibrillation with a fast ventricular rate, which we talked about earlier. Rate control, plus or minus anticoagulation, depending on duration, etc. Of course, if they have any of these, you don't mess around. You call your anaesthetist because they're unstable and you electrically shock them. Yeah? That's the way to think about these patients. Unstable, yes or no. If unstable, anaesthetist, shock. If not unstable, you have time. If it's SVT, vagal, and then adenosine. There are other drugs you can give, but those are the first two tiers of treatment. Is everyone happy with that?